Thank you for asking me to speak at the UOSSM meeting. My talk is entitled Obesity Guidelines, Diagnosis, Treatments, and Impact on Vulnerable Communities. Here are my disclosures, my grants, research support, my honoraria, speaking bureaus, consulting fees, and other work. The objectives are to recognize how doctors may have obesity bias and impacts the management of obesity, discuss the approach to weight management using the Canadian Obesity Guidelines, and also discuss the approach to weight management for the vulnerable populations. Let's start by stating the obvious. Obesity is a pandemic. It affects around 650 million people across the globe and 9 million people here within Canada. But we know who is most affected, and that's the vulnerable populations. This oversight causation map helps us to understand the drivers of obesity. And this includes socioeconomic influence, which is structural racism and marginalization. Due to this driver of socioeconomics, we see that obesity disproportionately affects the marginalized people, the Indigenous, Black people, and the poor. I'll first discuss obesity guidelines and the advances made within the field, and then turn back to how we can have an impact on marginalized groups. Fixing obesity is hard, but it is not impossible. We put together the Canadian guidelines to address the current treatment of obesity. It took over 3 years, 62 authors, and was published in August 2020. The Obesity Guidelines were the #1 most read article in the CMAJ in 2020. This was an exciting time for us. And I believe that the excitement was due to the focus on the bias and discrimination within the guidelines. The weight bias chapter is the first chapter in the guidelines. And the last chapter is obesity management with Indigenous people. In Canada, Indigenous people have the highest rates of obesity and diabetes and the worst care due to bias and systemic racism. We wanted to bookend the Canadian Obesity Guidelines with these chapters, bias and working with the Indigenous. When we address discrimination, we can now actually make a change within this field. Weight bias or obesity bias refers to negative attitudes and views about obesity and about people living with obesity. Implicit bias is unconscious bias, and explicit bias is conscious bias. Here's the thing, almost everyone has weight bias, both implicit and explicit. How can I be so sure of this statement? Studies show that obesity bias starts in preschool. If you show a child in preschool a picture of a child living with obesity versus a child with a disability, the preschooler will never choose the child with an elevated weight as a playmate. They also start to assign negative attributes to those with obesity, including laziness, lack of intellect, and other harmful traits. This bias continues well past preschool and is seen in doctors and healthcare providers. 70% of people living with obesity state that they experience stigma from healthcare providers. And then weight stigma. Weight stigma are those negative images that reinforce our biases. Essentially, they are stereotypes. If you Google obesity and images right now, you'll find that 72% of images stigmatize people living with obesity, and that's a real shame. Let's say you wanted to do a PowerPoint presentation and you wanted to put a picture of a man living with obesity in the presentation. So I want you to do this activity now. Google obesity, man, and images, and tell me what you see. You'll see images of people wearing clothes too small for them, riding up their bellies as if they don't know how to dress, or images of them in unflattering positions. This is hurtful, it's belittling, and it should stop. If you belong to any group and you see images of your people in this negative way, how would you feel about it? So we should do our best to try to recognize that these images are here and try to reverse them as much as possible. So instead of these images, Obesity Canada has an image bank where there are free images of people living with obesity who are active, moving, and dressed in an appropriate fashion. These are the images that should be displayed. After dealing with weight bias of healthcare providers, we now have to battle the issue of internalized weight bias. People with obesity hear all the same messages and see the same stigmatizing pictures and believe the same things all of society does, that they themselves have a character flaw and don't deserve care. Research has shown strong association between internalized weight bias and mental health outcomes, avoidance of exercise, and binge eating. The primary solution here is for healthcare providers to exhibit patience and compassion. So be patient with your patients and show compassion. Clearly, the biggest challenge driving this bias from healthcare providers is a lack of knowledge within the medical field regarding the science and the biology of obesity. This failure of our medical education system leads doctors to make recommendations such as eat less and exercise more. The simplistic message does not address the biology of obesity, and as a result, it does not work as a treatment. One of our first changes to the guidelines was to redefine obesity based on evidence in our work within bias and stigma. Obesity should not be defined by size or bigness, but by the presence of diseases that are associated with abnormal body fat. Therefore, we should move away from BMI when treating an individual patient. BMI is still used for population research, but on an individual level, we should use medical conditions as our marker. The science of obesity is rooted in our genes. There are greater than 140 genetic regions that are now known to influence obesity trait. The three areas of the brain most involved in this genetic coding and driving obesity are depicted here: the mesolimbic system, the hypothalamus area, and the frontal lobe. These regions of the brain are primarily designed to protect against weight loss. The intensity of this protection is driven by this genetic coding. As we gain greater understanding of the workings of the brain as it relates to obesity, we can develop treatments that work in these specific areas. Our current understanding of the brain and the gut hormones has helped us to design treatments that actually work: psychological intervention, pharmacotherapy, and bariatric surgery. Bariatric surgery remains the gold standard for severe obesity, especially for those with a BMI greater than 40 and those with type 2 diabetes. Bariatric surgery derives neurohormonal changes within the brain that allow the body to actually use stored energy and not increase fat storage. Again, this bariatric surgery is more a brain surgery than it is a gut surgery. So based on this science, there are now options for pharmacotherapy also. We have some medications approved within Canada and some very exciting news on emerging medications. Liraglutide was the first effective weight management medication to come to Canada in 2015. It was not all that long ago. It demonstrated about an 8% weight loss. The average weight loss that we see without medications is less than 3%. So seeing 8% was a big improvement. The second effective drug to hit Canada was a combination drug, naltrexone bupropion, also getting up to 8% weight loss in the completers. So it is an exciting time for us as Health Canada has approved just in November 2021 the most effective medication for obesity to date. Semaglutide 2.4 milligrams for weight management. It was approved in those with and without diabetes for weight management. Here we finally cracked the 10% average weight loss, getting up to almost 15% weight loss with semaglutide 2.4 milligrams. The Canadian guidelines were a Canadian success and an international success. News stories range from Australia to the UK, and adaptations of the guidelines have occurred in Chile and also in Ireland. What made these guidelines a success, I believe, was our ability to cover bias and discrimination. The marginalized in Canada face the brunt of chronic diseases. I'll go through this by first talking about our Indigenous community. Obesity rates are much higher in Indigenous people, about 1.6 times higher. This study from 2007 to 2010 looked at obesity rates in some of the First Nations people, up to 26%, compared to the non-Aboriginal groups within the study, which at that time were at 16%. So data is sparsely collected within Canada, and exact numbers are actually hard to get. But this reflection of higher rates has been seen in many Indigenous communities. And so when we looked at doing the actual guidelines, instead of just looking at only evidence-based approaches to the Indigenous chapter, as there is a significant lack of specific randomized controlled studies, we looked at evidence-informed recommendations. Here we got a group of elders and experts within the field to sit around a table and have an appropriate discussion about obesity management. And here's some of the themes that end up coming out of those discussions. Addictions and obesity are fused together because of years of abuse. Some people suppress these memories with eating. This was said by a male Cree who was age 30 and who was at age 32. Here are some of the specific recommendations that came out of that chapter. For instance, validate the patient's experience of stress and systemic disadvantage influencing poor health and obesity, exploring elements of their environment where reduced stress could shift behaviors. And again here, expect patient mistrust in health systems. Reposition yourself as a helper to the patient instead of as an expert, which may stir resistance and be a barrier to their wellness. These are recommendations that really come from the heart and are really speak to the Indigenous experience. I would now like to address obesity within the Black population, another marginalized group. For this section, I will rely mainly on American data as Canadians do not collect ethnic-based health data. This is a mistake and leads to a lack of understanding of the challenges within marginalized groups. Here are the stats on obesity by race within America. Overall, obesity rates in America are staggering, but it's clear that Black Americans are affected more than white Americans. There is 50% obesity BMI greater than 30 in Black Americans, and 42% within white Americans. This disparity is driven by Black women at 57% versus white women at 40%. This is almost a 50% higher rate. This disparity in rates of obesity and disparity in health was not by chance. It was by design and started in slavery and lives on today in structural racism. So what is structural racism? First, let's look at the definition of racism. Racism is defined as any prejudice against someone because of their race. But if we leave it there, we only deal with overt acts of racism. The real issue is a racism that most of the world practices every day, and that is systemic or structural racism. So racism should be defined as any prejudice against someone because of their race when those views are reinforced by systems of power. And here's the thing, structural racism works with or without you. Structural racism doesn't mean lots of racists in the system. It means that even if there were zero racists present, the system would still disproportionately harm people of certain backgrounds. It is a machine that runs whether we pull the levers or not. By just letting it be, we're responsible for what it produces. To understand the origins of these disparities, we need to go back to the days of slavery. Let's look at the slave rations. The objective of the slave owner was to keep his investment working with bare minimum investment in food and provisions. This led to diets heavy in carbs, salt, and excess calories from poor nutrition foods that could be burned off during the working day. Other food was obtained by what the slave could grow or catch, but disease and poor hygienic conditions led to multiple deficiencies and diseases. Today's food options for Black people are derived from days of slavery, high starch, fat, sodium, cholesterol, and high caloric content. Inexpensive and often low quality nature of the ingredients such as salted pork and cornmeal. The collision of food insecurity, and in this case, being the inability to acquire or consume an adequate diet quality, colliding with biology, poverty, and structural racism leads to a troubling aspect of obesity in Black women in America. We need to remember that Black women preferentially put energy into peripheral stores, but up to a BMI of only about 32. And after that, energy also goes to fat stores in the visceral area, leading to metabolic diseases. Although most of our data is from the US, I've personally conducted research and collected race-based data. We looked at the results of weight management at a community-based clinic in over 9,000 patients. We found that overall, women of color, and this includes South Asians, Black, and the indigenous women, lost less weight than white women did. When we adjusted for the number of visits to the clinic, there was no difference. So the issue was access to care. We could not easily reach women of color, or they could not reach us, i.e. take time off work in the middle of the day or find the resources for healthy eating options. The system was not built for them, but for those with privilege. We've been working on solutions to correct this by starting to use virtual care to reach women within their homes and at work. So what are the solutions to disparity in care within medicine? There's no single solution here that can undo hundreds of years of racism, and solutions will need to come from a wide range of places, organizations, and also individuals. So in conclusion, bias and stigma has limited obesity advancements and obesity treatment. But treatment for obesity exists, and it's rooted in neuroscience, brain neurochemistry. It includes surgical options, medications, and psychological intervention. Obesity rates are much higher within the marginalized groups. Structural racism is rooted in slavery and perpetuates the conditions that fuel obesity. Solutions include improved recognition of this disparity and addressing structural barriers to care for the indigenous people and people of color. Thank you. This is my son, James. He's 16 months old now, but this was him at 4 months old when he had taken to raising his fist in the show of solidarity, I believe, for all marginalized people. Thank you for your time.